Good afternoon. Welcome to Macular Surgery. My name is Lee Tae Woo, and I'm going to be co-chairing this session with my friend Hussein Kwan. He should be here shortly. Because of time, we're going to start. I'm going to be the first speaker. I will be speaking in OCT biomarkers in ERM, and we will keep questions until the very end just so we stay in time.
This one.
Where are my slides?
Have you made this in any other operating system? Like Mac
Can
or
we
something?
get my slides here, please?
We might need a MacBook for
Hello?
to play this. Yeah, just a second, sir. Do you have a MacBook? It's in this one.
Okay.
Which one?
Hang on. This one, the third one.
This one?
Yes. Yep. Mm-hmm. Okay. All right. So
Do you want a MacBook?
these are my
This might be on MacBook
disclosures,
because
none
the
of which are
Windows is
really
not supported
relevant
by
to this talk. So we're going to be talking about epiretinal membrane treatment, and we know that the best predictor of post-op visual acuity is the pre-op visual acuity. So if that's the case, early intervention when the visual acuity is good achieves better final visual acuity. However, if we delay surgery, we can potentially avoid surgery in many cases because we don't know if all the cases are going to progress. So the question becomes, when should we observe, when should we operate, and can we predict outcomes after surgery? So there's some natural history. You have the study, the Blue Mountains Eye study from Australia, and you can see here that doesn't really tell us much because close to 30% progress, about 40% remain stable, and 25% regressed. And if you see here, 207 patients with ERM, post-cataract extraction were followed prospectively, and you see that in 40% there was progression of the epiretinal membrane, a third remained stable, and there was regression in 25%. So it's really hard to really assess when to consider surgery. This is a recent study from Bascom Palmer where they looked at more than 400 eyes with mild primary ERM, and of these, about the majority did not undergo vitrectomy. So about 10% of them underwent a deferred vitrectomy, which was a defined up to a mean of 18 months. And the outcomes compared to those who underwent immediate vitrectomy was within 6 months of presentation. There was the comparison. And the risk factor most associated to progression to surgery was the presence of symptoms at presentation. So the final visual acuity was similar in both the deferred and the immediate surgical groups. And the median change from the pre-op to post-op best corrected visual acuity did not differ between deferred and immediate surgical groups. So in other words, you can actually don't need to entertain surgery immediately after you make the diagnosis. You can wait, and most likely the results are going to be about the same. These are the pre-op factors associated with conversion to surgery in eyes with an initial good visual acuity. So if you have a higher baseline CMT, the presence of ELM or EZ disruption, or the loss of foveal contour, the presence of metamorphopsia or presence of visual symptoms, these are patients that will probably require surgery. In terms of the spectral domain OCT biomarkers, we're looking at the biomarkers that may predict the post-op best corrected visual acuity. And of these, we look at the integrity of the ellipsoid band, the integrity of the interdigitation zone band, and the length of the photoreceptor outer segment. There are many publications here that have been focused on the outer retina. However, the evaluation of the outer retinal integrity may be limited due to the SDOCT imaging artifacts that are fairly common and can give us the wrong idea. So after that, other authors look at the main, saying that the main pathologic mechanisms of ERM involves tangential tractions on the inner retinal layers, and the outer retinal analysis alone is insufficient to reliably predict outcomes. So the continuous ectopic inner foveal layers was associated with a significant visual loss. That's where Govetto and collaborators did this new classification where we look at this. This is stage 1. There's the presence of the foveal pit when the well-defined retinal layers. Stage 2 is, you see the ERM here. There's no longer the foveal pit, but the retinal layers are well-defined. Stage 3, you can see here, there's the absence of the foveal pit. There's well-defined retinal layers, and there's the presence of an ectopic inner foveal layer here. Stage 4 is when there's a big mess here. So we have disrupted retinal layers and the presence of ectopic inner foveal layers. So they used this information and looked at their own patients, 111 eyes, and they noted that the presence of the ectopic inner foveal layers was significantly associated with lower pre-op and post-op best corrected visual acuity, and also the thickness was negatively correlated with the pre-op best corrected visual acuity. Also, after doing the surgery, in most eyes, the EIFL persisted in over 90% of eyes, and the EFI thickness decreased significantly after surgery, but the post-op thinning did not have a direct effect on post-op best corrected visual acuity change. So the presence of EFL is a negative prognostic factor for post-op anatomical and functional recovery. This suggests that perhaps the timing of when to do surgery is before we reach stage 3. So this was a study from Canada that they wanted to validate this new classification. And you can see again that indeed they were able to show that also the staging had an impact on the postoperative visual acuity. And you can see here that only 5% of stage 4 eyes achieve a final visual best corrected visual acuity of 20/40 or better. So again, they recommend surgery in stage 2 that can result in significantly better visual outcomes and a greater chance of reversibility of anatomic changes. So we decided to do a study similar to this. This we presented at Vitrectomy just a few months ago. These are my co-authors. And the objective of our study was to validate Govetto staging as a predictive tool for ERM surgical outcomes and to assess the long-term clinical significance of these ectopic inner foveal layer at 5 years of follow-up. This was a retrospective multi-center study, 65 eyes with 64 patients, and all the patients had a follow-up of 5 years. The pre- and post-op SDOCT scans were analyzed by 2 of us. And you can see here over time the best corrected visual acuity that it improves. And even after 5 years, the visual acuity remained pretty significantly better. So there was, this is in line with some studies that show that the results after surgery are maintained. These are our results here, and we can look at what influences the pre-op best corrected visual acuity. So the central foveal thickness, the ERM staging, and are the factors that are associated with a best corrected visual acuity. We also looked at CME, easy disruption, the cotton ball signs, and the presence of the EIFL were not associated with the pre-op best corrected visual acuity. The limitations of this studies was that we didn't have any measurements of metamorphopsia, the small numbers, and we conclude that results of surgical repair of ERM are long-standing. The pre-op ERM staging predicts pre- and post-operative best corrected visual acuity, and the presence of post-op CME and thicker CFT is associated with a poorer post-op best corrected visual acuity. More recently, this group used machine learning model that was developed using the data of 67 patients who underwent vitrectomy and membrane peel, and the pre-op visual acuity and the size of the ectopic inner foveal layer significantly influenced the post-op visual acuity. So in summary, the pre-op best corrected visual acuity remains an important determinant of post-op visual acuity. The ectopic interfoveal layer may predict the visual outcomes following vitrectomy and membrane peel, and AI may help predict the visual outcomes. Thank you very much for your attention. So the next speaker is going to be Mohammed Samir, macular buckling, different techniques. Okay, so can I ask Dr. Agnieszka Nowosielska, macular hole treatment in retinitis pigmentosa.
Good afternoon, everyone, and it's great to be here, and it's an honor and a pleasure to have this presentation. Today, I would like to say a few words about macular hole surgery in retinitis pigmentosa, and because this is very rare disorder, this kind of surgery will not be your everyday practice probably, but I hope you find it very interesting. We know what retinitis pigmentosa is. This is inherited disorder, and the patient experienced the loss of vision and the loss of peripheral visual field. However, what is very important in retinitis pigmentosa, those eyes develop also macular pathologies, and the prevalence is around 80% of them. They have some sort of pathology. The most prevalent is epiretinal membrane, but vitreomacular traction is also quite frequent, lamellar holes, but the major study that was published in 2019 did not find even one single case of macular holes. So macular holes are really, really rare in those patients. Here is the surgery which I performed more than 10 years ago. Because at that time the reverted flap technique was not popular, was not presented yet, and I myself was not smart enough to invent it because, as you can see with the flap that I create, I could easily do the inverted flap, but I had no idea I could do that. But what I wanted to point here is the yellowish tissue that you could see in a moment. This tissue is like retinal proliferation seen in pseudoholes or lamellar holes, which is quite resembling what we can see in those different disorders. Here is the OCT of the patient, and although the hole was quite small, you can appreciate the morphology is totally different than the idiopathic macular hole. You can see the epiretinal tissue, which is pointed with the red arrow. And what is quite important, this patient waited 3 years to be operated on because actually nobody was eager to do the surgery because of obvious reason. This is the second surgery that I did recently, last year actually, and you can see here that I'm trying to peel the ILM, which is difficult. The ILM is not stained well. It comes in pieces, so actually creating the flap would be very difficult. This retina is very, very thin, so actually on a table you could have the feeling that when you touch the ILM, you touch the sclera, which is underneath. And in the end, I just ended up with just clinical peeling because no flap was able to be created. This is the OCT of the patient, and again, the morphology of the macular hole is different than in idiopathic macular hole. The hole was closed, but you can see that architecture of the retina is different, much different than from the healthy retina. So is it worth operating on? Yes, it is worth operating on because the central field is the only field that those patients have. And you need to understand and remember that with a little vision that they have, this is actually the world they don't have anymore. They don't have a spare eye to be implanted as a third one. The ILM peeling will be difficult, the staining will be difficult, the retina is very thin, and you need to be prepared to change the scenario of your operation while you proceed. But those patients are very thankful, so if you ever come across such a patient, please try your best. Thank you so much.
Thank you. So we're having some problems with visa issues. So Marcelo Sass is not here. I don't see Francesco Boccia, and I just got a text message from my co-chair, Hussein Takwan, saying that he also was not going to be here, as well as Nicola Gassi. So the next speaker is going to be Mohamed Hazazi, who's going to be speaking on surgical management of submacular hemorrhage.
This one, is it? This file?
Yeah, the last one. Thank you very much for the introduction. Thank you for the organizers. So this is my talk. I'm going to talk about a general approach of the management of the submacular hemorrhage and my preferred technique as well. I have no disclosure. So why submacular hemorrhage is harmful? We know that the blood in the under the retina cause stripping of the photoreceptors, and this will cause damage mechanically. It causes also toxicity to the photoreceptors by the iron deposit, and also it can cause like a barrier of the RPE and neurosensory retina. And it has been shown that in experiments that within 24 hours, the permanent effect on the photoreceptors can occur. The etiologies are numerous. The most common one is the choroidal neovascular membrane, secondary to AMD. There are few factors that are associated with the poor visual acuity even after the treatment, which is the presence of choroidal neovascular membrane, the thickness. There is no consensus about how much thickness is more harmful. However, most of the literature talking about more than 400 microns. AMD etiology and the large area of the hemorrhage. Here, what is important to know that the shorter the radius of the submacular hemorrhage at the center of the fovea has more favorable outcome and the intact of the ellipsoid zone and anterior limiting membrane. There are few things that you need to look in the OCT. There are 4 things that are very important. The most important one is the level of the submacular hemorrhage, if it's centered in the fovea or it's away. The second thing is the measurement of the thickness. Again, we mentioned that it's around 400 microns. The third thing, which is the reflectivity. So the reflectance will give you indirect way of measuring whether this is really involving the center of the fovea and need to be treated. And the last one is the intact of the ellipsoid zone and the external limiting membrane. In the OCT down, you can see the one on your left, where you can see an elevation. However, if you see the high reflectivity, is only one part of it. The remaining is kind of serous fluid. So this is less harmful to the photoreceptors. However, on the right side, you can see more of hyperreflectivity, which is representing more of clot and more of blood. So what are the treatment options? It can be observation in small hemorrhages under the retina. You can also proceed with only monotherapy of anti-VEGF alone, and you can also use the either pneumatic displacement along with TPA or without. Is there any, what is the preference of anti-VEGF? The anti-VEGF monotherapy has viable option for the treatment of submacular hemorrhage secondary to AMD. Studies has shown that good visual outcome with 44 to 60% of eyes achieving in 3 to 4 months improvement at 6 months. And the eyes with more than 450 micron achieve better outcome if it's combined both therapy. However, monotherapy also has shown to be effective. So is there any preference, any kind of anti-VEGF to be used? There were no evidence supporting any kind of anti-VEGF on top of other. However, it has been shown that aflibercept showed cleaved by the TBA whenever it's combined in vitro, and this will decrease its effectiveness. Pneumatic displacement, it pushes the blood away from the fovea. It can be performed with or without the intravitreal or subretinal TBA. It has been also shown its effect in the displacing the submacular hemorrhage without the use of TBA, for example, completing the displacement in about 80% within 1 week alone. Moreover, it provides also an added benefit of faster visual recovery, and also if you're going to treat the patient with, let's say, laser and need visualization after the use of ICG, this will help you to displace the blood away from the center. It's not any more different than if you are doing pneumatic retinopexy. Those who are familiar with doing pneumatic retinopexy for treatment of retinal detachment, this is just a simple, straightforward technique. So let's talk about the TBA. TBA can be injected in the subretinal space, and this require some preparation. However, it can be injected in the vitreous cavity, and I'm gonna show you that it is less invasive and it has less time consuming, and technically it's not challenging. You are just doing this if you are injecting an anti-VEGF. And some of the studies that confirm that the TBA injection intravitreally can migrate across the vitreous cavity and to the retina under the retinal space. This study looked at comparing if you are injecting the TBA in the vitreous cavity or in the subretinal space, and it has been found that the outcome after 6 weeks post-operatively, 100% of the patient with subretinal TBA compared to 97 if you are injecting this in the vitreous cavity. And this is actually a very nice comparison and very nice results. In terms of vision after 6 months, it showed a similar visual outcome. And those results suggesting that the intravitreal TBA injection may be sufficient to affect dissolution of the submacular hemorrhage and effectively in similar way compared to subretinal TBA. This is another study also comparing the use of subretinal TBA compared to intravitreal TBA, and you can see as a conclusion both treatments showed equal efficacy in displacing the blood. So let's take some of the few examples. This is only a patient with presenting with a hemorrhage secondary to AMD with drop of vision. You can see after 5 months of monthly injection of anti-VEGF alone, the visual acuity improved to 20/30. This is another case with only pneumatic displacement, pushing the blood away from the center. Again, good results. This is a young patient presented with sudden decrease of visual acuity, and you can see in the OCT on the right side, the blood is under the fovea. This is my preferred technique where I inject the intravitreal anti-VEGF along with the TBA in the first session. Then I bring the patient second day with a bubble, and you can see the bubble displacing the blood away, and the patient improve in his visual acuity. This is how the OCT look like at week 1. Then the visual acuity improved to 20/50 on the second week. 1 month later, the same patient presented with the same complaint. However, this time, if you look at the OCT on the right side, now the blood is under the RPE, it's not under the retina, so it's not as harmful as it is in the subretinal space. So the treatment was different. I just injected the patient with anti-VEGF. Then I took the patient for ICG, and I discovered that the patient is showing, you can see it maybe if this is possible, you can see there is a polyp here, which is extrafovea, which was treated only with laser. Patient for the last 2 years, he's doing fine, no more bleeding. This is another 72-year-old male presented with the same complaint, treated with the same way. You can look at the OCT. If you take the cut, which in this location, it's showing blood. However, if you go to the fovea, it's only very minimal blood in the subretinal space. So again, this patient was treated with the same maneuver, intravitreal anti-VEGF with intravitreal TBA. Then the next day, patient is placed back with in face down position after the injection of one. Do I get?
Go ahead.
Yeah.
Keep on going.
Then a gas bubble, which was injected the second day. And the rationale for this, I give, especially in AMD cases, I give a chance for the first day with anti-VEGF and TBA, and ask the patient to be on supine position where the anti-VEGF and TBA will be in contact with the retina. For the next day, patient will be placed with in face down position where the bubble will be pushing the blood away after it has the maximum effect where the TBA already started to work on the first day. So this is 1 week later, you can see the blood is displaced inferiorly. This is the same patient 2 weeks later, his visual acuity improved to 20/60. This is another diabetic patient with, again, some macular hemorrhage, was injected with TBA, and this is the result. Subretinal TBA technique, it's again, it does not require a steep learning curve because you do have actually an elevated retina, so it's easy to be injected. How much you inject, I usually prefer not to inject more than 0.5 ml of TBA to avoid iatrogenic macro hole. Then air fluid exchange and bubble if we are going to do the subretinal TBA. Again, this is the surgery. It shows you how there is already an blip with the blood elevating the retina, so it's somehow safe to go in the subretinal space. It does not require a steep learning curve. How big is the bubble? I always prefer, if you do only the intravitreal TBA, to have a medium-sized bubble, not to have as large as this one, because this will give a chance for the bubble to push the blood away from the center. So again, this is the token message. There is no clear guidelines or special technique to treat the macular hemorrhage. Maybe the most important is the aerial intervention, which can give a better outcome. Treatment strategy depends on how large is the macular hemorrhage, the availability of the instrument that you can use for this one, which is the availability of the 41 or 38 gauge cannula and the TBA in the OR, the time of presentation, and your preference to go as office-based, less invasive injection with intravitreal compared to if you go to vitrectomy along with subretinal TBA. Thank you very much.
Very good. We're going to continue now with Dr. Mohammed Samir, who's going to be talking about macular buckling, different techniques.
Okay. I'm talking today about macular buckling, different technique. In high myopic eyes, the axial elongation of the eye is a very challenging condition, And the development of the posterior staphyloma results in thinning of the retina and choroid, which lead to myopic maculopathy. As we see here, fundus photography taken by Optos, in which the upper edges of the staphyloma is pigmented in the pseudocolor images with granular hypoautofluorescence. And as we're going to see in the next slides, the effect of the posterior staphyloma and the myopic traction maculopathy. The myopic traction maculopathy is a wide spectrum of clinical pictures that may affect up to 30% of eyes with pathological myopia, with and without posterior staphyloma. We have different classification. We have the old classification, myopic fovascisis, partial thickness macular hole, full thickness macular hole retinal detachment, and the last and the recent classification of Barbara Parolini, which is addressing the tangential and the anteroposterior traction elements. The mechanism of myopic macular hole retinal detachment in these cases is due to the tangential traction on the macular surface and anteroposterior vitreoretinal traction and the reduced retinal adherence because of the atrophy of the RPE. So this is the first case in our series, 46 years old patient with myopic hole retinal detachment due to high myopia. We used in this case the what's called endoplumb, or the macular plumb and the macular buckle. As we're going to see, we put 18 millimeter from the limbus staying suture, 7 millimeter apart, and taking the stay sutures in the sclera and putting the endoplumb, which is the macular buckle we are speaking about, or addressing in our presentation. It is malleable. It is flexible. It has a titanium wire inside, so it has a good memory. And after we put it, we inject. We don't do vitrectomy in these cases. We don't enter inside the vitreous. We don't put silicone or something like that. And this is the result. This is the second day post-macular buckling. This is an air bubble. We put it to get the pressure of the eye within normal. It succeeded, but unfortunately, after 5 days, we have a recurrence. What is the cause of this recurrence? The cause of this recurrence is that the endoplumb, the end, is not actually on the hole. This is the indentation part of the plumb. So we make what's called a modification in this endoplumb, while putting a fibro light in this plumb at the end of the plumb, 23 gauge or 25 gauge light. This light, while using it during the operation, I will fix it in the right way at the posterior pole, or at the right way at the macula, so increasing the incidence in this in the success rate of these cases, as we are going to see in the video. Putting the plumb like that and entering, seeing through the indirect ophthalmoscope or even the microscope, the indentation light, as we are going to see in this video, and putting the indentation light at the proper area, which is at the macular hole, myopic macular hole, to buckle this myopic macular hole and to configure the posterior aspect of the globe. And this is the most strong point in treating the posterior staphyloma in myopic traction maculopathy is conforming the posterior pole configuration by using the macular buckle. After that, we inject air bubble to conform the globe. And as we are going to see now, taking the stitches, the last stitches, and this is the successful indentation, the macula in place. And this is 1 week post-operative OCT, mild fluid around the myopic macular hole, and we are seeing also the closure of this macular hole in this slide. This is after 1 month, no fluid, and the macular hole closed. And this is our paper. The last slide, there is a new what's called titanium buckle by our friend Akduman. This is a titanium, totally titanium buckle. This is, as we see here, myopic traction maculopathy case, putting 17 millimeter from the limbus, taking the stay suture as we are watching the video, and starting to introduce the buckle. This buckle is very hard. It's not flexible like the end plumb. But it has a good results. It causes a good and strong indentation effect at the posterior pole, as we are going to see now in this part of the video. This is the buckle. It has two knobs at the anterior part to be fixated. Putting it, and we can manipulate it while using, as we are going to see in the video, a chandelier light, and I can see the indentation effect of this buckle and adjusting the plate of the buckle at the posterior pole, as we are going to see in the video. It doesn't need a long learning curve from the surgeon, but it needs to be oriented with the anatomy of the posterior pole and the posterior staphyloma, as we are going to see here. This is the indentation effect of the buckle. This is the indentation effect of the buckle, and I'm using this indentation to move it to accommodate the staphyloma at the posterior pole and at the macular part, as we are going to see now. So moving the buckle and adjusting its place while putting the chandelier light, as we are going to see now. It's not a hard procedure, or it's not a difficult procedure, but it's important to put it in the right way. After that, we are going to take the sutures and to fix it and close the conjunctiva without doing vitrectomy. We don't enter inside the eye. We don't remove the posterior hyaloid. We don't be confronted with iatrogenic breaks or iatrogenic macular hole, and this is the indentation of the buckle, and this is our sign of success. And it was nice that we just has published this procedure in last February. Thank you very much.
So now I'm going to ask Dr. Nair, who's going to be talking in OCT, multimodal imaging of macular diseases.
Change of pace over here. We're just going to go a little bit into the medical management and a few OCT features in a very simple presentation. So we call it the 10 Commandments, okay? So the first, we're going to say that kindly realize, thou shalt realize that autofluorescence is a very powerful tool. And how do you know that? We use it for geographic atrophy progression, diagnosis, and progression over years. There are many things to look at, including the hyperautofluorescence areas, the progression, the shape, the edge of the autofluorescent black. So if you have a curved round circular edge, it means it's less advancing. If you have a scalloped edge, it means it's a faster advancing edge. So the use of autofluorescence. Again, in CSR, we know it's easy for us to diagnose CSR with OCT, but the presence of autofluorescence tells us about recent disease activity. So here you see a patient where the fluid amount is less, but the amount of autofluorescence is a much greater area, telling us that there was a lot of recent activity. The diagnosis between different types of CSR. In this patient, you see cystoid macular edema, while in the autofluorescence, you see extensive areas of without intermittent area being free. That tells us this is beyond a regular CSR, it's beyond multifocal CSR, and it's reached a stage where the RP is sick, and it's called the sick RP syndrome, or a diffuse retinopigment epitheliopathy. This is another case where the progression of the disease from simple CSR to multifocal CSR to sick RP syndrome is well documented in these patients. Another patient where you have asymmetrical macular degeneration with a lot of dropout areas. The right eye and the left eye, you can now say that the visual acuity is going to be poorer, or the macula is going to be worse in the right eye, but the areas of hypoautofluorescence in the center. Again, differentiating Stargardt's disease with the flex being hyperautofluorescent and the macular atrophy areas being hypoautofluorescent. a marker of activity in certain diseases called serpiginous retinopathy. You can see that this is a patient who's undergone the disease and there's no active disease, there's no hyperautofluorescence. In a condition like this where you see a yellow spot in the center, and in the center you see an hyperautofluorescence, and this is an adult vitiliform degeneration patient. The next thing is that thou shalt not assume everything you see is fluid. A typical case of this would be mactal, where you have cystoid spaces. This is not cystoid macular edema. This is an area of an inner cystoid or inner reflective, hyperreflective lamellae. Again, in a vitiliform deposit where there's resorption of the deposit, it may look like subretinal fluid, but it is actually a resorption of the vitiliform material, and you can see it in this patient. Another condition where you see an area that looks like subretinal fluid, and this is a case of a torpedo maculopathy or a chorioretinal atrophy or dystrophy. This is another case of a torpedo maculopathy. Here you see a small elevation, and it could appear that it is fluid. This is a typical case of an outer retinal tubulation that happens on a dystrophic RP, a sign of a scar becoming established and the photoreceptors getting secluded above that. Thou shalt understand everything is not about just measuring the CFT. Biomarkers in DME include a lot of biomarkers, including drill, disruptions of the outer plexiform, the outer retinal health, the hyperreflective dots. So here you see what do you mean by drill? Drill is when the outer retinal layers are not, the inner retinal layers are not uniform and can be recognized. On the temporal side of the fovea, you see there's no differentiation between the inner retinal layers, and this is drill, disorganized retinal inner layers, and it's a key marker of visual acuity return after treatment of macular edema. So in this patient, you see there's edema, but after there's recovery, you can still see that the layers are distinct, and this could form a better prognosis against recurrence and all those things. Ellipsoid disruption, as we say, the outer retinal layers could be the keystone for having a good visual acuity. Here you see the ellipsoid zone is disrupted in these patients. Outer plexiform disruption is more when you see full thickness or full extensive cysts, and the outer plexiform layers, which are the vertical elements where take it out, you can see that they are disrupted, and that is a biomarker for poor visual acuity. Hyperreflective dots are macrophage containing lipids, which indicate a tendency to hard X-ray formation, a more inflammatory component of pathogenesis towards diabetic macular edema. Parallelism of the retina, that is when there is good parallelism, it means that the structure and relationship of the structure to each other is good. This is an example of good parallelism, and this is an example when the edema is too much, the layers are thrown into different segmentations and you cannot identify the different layers amongst each other. So this is an example of poor visual acuity. There is more to ERMs and macular holes. This is an example of two surface pathologies. On the upper side, you see something called the LHEP, or the lamellar hole epiretinal proliferation. The lower is a tractional hole. So these are two types of lamellar holes. One is degenerative. The degenerative has a different appearance. The deeper layers are affected because it's degenerative, and you see a presence of an epiretinal proliferation, not tractional tissue. In a tractional hole, you see a surface tissue, and there's splitting of the retina, like you see the splitting of the inner layers of the retina in a mustache-type pattern, and you see the retinal cystoid changes. So this is an example where you see both changes. You see the LHEP change, and you also see the tractional retinal change with the top hat pattern and also the skytic cystoid pattern. Thou shalt listen to what drusen tell you. There are different types of drusen. It's very interesting to know that each drusen is divided into different types based on the shape, the internal reflectivity. Here you can see concave drusen and convex drusen. The pointed ones are concave, and the rounded ones are convex. You see drusen which has a uniform interior. You see drusen which has heterogeneous interior. The drusen which has heterogeneous interior, and something that you see on the extreme right-hand corner are hyperreflective, so that's called a core. Drusen with core and drusen which are heterogeneous have a greater propensity to go to RP atrophy or geographic atrophy. So these are all the features you can see, and in these pictures you see all the time. You see homogeneous drusen, heterogeneous drusen, you see sawtooth drusen and geographic atrophy. So these are just examples of what happens to drusen. You see a drusen exactly in the center with hyperreflective dots inside, and over time you see the nature change. That is, it becomes heterogeneous inside, and you see hyperreflective dots. These are all indicators of future or potential nascent or geographic atrophy happening. you should watch the RP carefully before it atrophies. So this is nascent geographic atrophy, where the subsidence or the layers move down towards the ellipsoid zone, you see, in that particular point. And that is because the vertical support of the photoreceptor support is lost. And just before this happens, you have changes where you see hyperreflective foci happening. Those are detached RPE cells leaving the RP, and that's a precursor of diagnosing nascent geographic atrophy or RP atrophy. And again, whenever you have an RP atrophy, you have these vertical columns happening. Those are called sub-RP hyperreflective columns. Another evidence that the RP is about to atrophy before it goes to geographic atrophy. And this is a very consistent sign when you're evaluating geographic atrophy. So this is kind of I think a 12-year follow-up of a patient over years, and you can see all the changes, including hyperreflective foci happening, degeneration, adult vitelliform degeneration, and finally the patient goes into iRORA, which the hypertransmission increases and the geographic atrophy component increases. Thou shalt be knowledgeable of the different types of PEDs. So you have something called giant PEDs. We have huge locations have a feature of PCV and all those lesions. Extra large PEDs more than 1,000 microns are an indication for an imminent RIP or an imminent subretinal hemorrhage. These are called thumb-shaped PEDs, typical of PCV, like you see there. These are fibrovascular PEDs, where you see the vascular tissue right under the surface of the PEDs. This is called a multi-layered PD, where you see lamellae inside. It's kind of good prognostic, considered a good prognostic feature nowadays. And these are the lamellae you see inside the PEDs, and which is fibrosing effects. Again, so this could be suggestive of a RAP lesion, where you see fibrovascular tissue underneath it and a small amount of SRF above it. Thou shalt know what to expect when the choroid is thickened. So pachychoroid is a flavor of the day now, where you see thickened pachy lesions. You have different forms, CSR being the most simple form. Pachychoroid geographic atrophy. You see pachyducin with small amounts of fluid on the top of the surface. Peripapillary pachychoroid syndrome, where the thickness of the choroid is on the nasal thing, and you see cystoid changes rather than SRF on top of the papillomacular bundle. And this could eventually lead into having having a CNVM, a pachychoroid pigment epitheliopathy, where you have small changes which look like old CSR but can convert into up to PCV at a later date. When you see a double layer sign, you could always think that this could be harboring a neovascular process underneath it, and it could break into a frank SRF later. And this is what extensive filamentous membrane underneath the double layer sign could look like. And the last would be about OCT angiography, where you see making tremendous strides into diagnosing vascular networks, differentiating between type 1 and type 2 membranes. This is a typical type 1 membrane with a filamentous thin thing with thin capillary fringe-like, a Mactel patient in which you can differentiate the presence of a CNVM on the, just a couple of
Just
slides.
ignore it.
Yeah, sorry about that.
No problem.
Yeah, and even in the diagnosis of PCV on the angiography, you can see clearly the polyps. But on the OCT angiography, you can see a wonderful branching neovascular network. It might be a bit more difficult to see the polyps on the OCTA, but one of the main uses of the OCTA nowadays is establishing recurrence of CNVMs. Here you see a beautiful picture where you see a capillary fringe and an anastomotic membrane. This is a brilliant image of a capillary fringe where you see small capillary vessels in a recurrence, and you see an anastomotic vessel going all around it. Again, the same theme. This is how a recurrence would look like, vessel running around it with small areas of budding. A patient which has on the temporal side, you have the capillary fringe happening, which tells you that this is a recurrence at that area. So just stuck over here. Yeah, just skip these. So when a CNVM fibroses or it goes away, it looks like this. It looks like a prune tree appearance. Only the big filamentous vessels and no small connecting vessels. And there are two patterns. One is called a skeletonization, in which you just see a frame, a broken framework of the whole neovascular membrane, and that tells you that it is nearly about to regress and go away. So the skeletonization and a fragmented vasculature is what you could be looking at, and it could be an indication for you to stop treatment. The last thing that the OCT has revealed is something called a non-exudative membrane. You see a small ripple or a double layer sign. There's no activity, but on the membrane, on an OCTA, you see a very faint blood vascular network. It is non-exudative. It's not yet reached exudation. And that is the thing. And the 10th commandment is that thou shalt respect the power of biomarkers. So there are many biomarkers in diabetic macular edema, some correlating vision, some correlating with response to anti-VEGF, recovery of vision, systemic control, and disorganization. And there are a lot in AMD also, which regard to the progressive atrophy, the persistence, the recovery from anti-VEGF, the recovery after anti-VEGF and recurrences. And some of them, as we said, mentioned today, the whole talk was about those related to surgical retina, including IFL, about recovery, ellipsoid, the hypertransmission, the ELM defects and easy defects, macular hole, post-operative recovery in macular hole also. So thank you very much. Thank you.
So we have a lot of time for questions. I'm going to open the floor now. Any burning questions? Let me start. What parameters do you use to operate or decide that you want to operate on epiretinal membrane? So let's start with Mohammed here. What do you? Vision. What is the vision cutoff? Or does it matter, or as long as the patient is symptomatic, or? So if the patient is 20/25, then you will not touch the eye. No, but if the patient is symptomatic. He says, doctor, I'm seeing lots of, everything's very distorted. He says, yes. Uh-huh. Yes. Yes, I agree with you guys. I think it's symptomatic regardless of the visual acuity, right? So I think we can all agree with that.
And another thing is that the patient might have different visual acuity requirements in their life.
That's correct.
80 years old female going to church only.
Yes.
She has totally different requirements than 50 years old architect. So they will come to your office and they will tell you totally different things. And sometimes I do the surgery when the vision is quite well because there is a demand from the patient because they need to be active, they need to work, and they need to see properly.
So this is very important what Dr. Novosilska has said. Always listen to the patient. Not everyone's needs are the same. Especially now we have all these OCTs that all our general ophthalmology colleagues just do routinely, and they see an ERM, they send it to you. But a lot of the patients are really asymptomatic. So those are the ones that you can probably follow. Okay. Yes.
Just like to make a point, we have the OCT biomarkers, basically two. One is the IFL, which is once the IFL comes, you're not going to have structural recovery back after surgery. That's what the studies say. And the second is
Well, I will disagree with you completely. It's not that they're not going to have recovery, but the chances of them having a recovery will be less. But still, even in stage 4 eyes that you operate on them, some percentage of persons will get 20/40 or better. So it's not completely absolute.
I was just mentioning, I was just thinking of another angle to it, not the visual recovery angle. If you document that the IFL is increasing and the patient still doesn't have a lot of metamorphopsia, would you wait for the patient to get metamorphopsia, or would you intervene when you establish that the IFL is increasing?
That's a very tricky question. But from a psychological point of view, it's quite tricky to persuade a person who doesn't feel that he needs the operation. There's a person
Yes.
sitting in front of you, and in his mind or her mind, he is absolutely perfect.
So can I
Okay?
put it like,
And you need to convince this person to do the surgery. And for some reason, it's always in life like that, that complication happens in those patients. So you need to keep the balance. And what I do, I tell them to come even each 2 months. And I wait for a slight, something for my conscience to give me the blessing to do the surgery. A little bit of curving. Or maybe you see some metamorphopsia, and I'm just saying, okay, because otherwise you will lose your vision.
Those are very wise words. Listen to her. I agree completely with her. Okay. Other questions? Okay, so let's move on now to Dr. Nowosilska and macular holes. Your case was in retinitis pigmentosa, which is kind of rare, but typical macular holes are more common. What is your preferred technique to close them? Do you always do now an inverted flap, or you just peel the ILM, or does it depend? What do you do?
Kind of depends. I mean, in the modern world, we all are persuaded that inverted flap is the technique of the choice and gives the better visual acuity, and it is the technique of choice. But sometimes if flap cannot be created, or you remove the ILM, or anything bad happens, I just convert to just classical technique. I was taught vitrectomy in Germany, so I'm used to the peeling from arcade to arcade. So I think that
And do you need to peel the ILM in all the cases?
of macular holes.
Yes. Small holes, do you think you need to, or just
I
peeling
usually-
the hyaloid is enough in those cases? Or?
You're right, but I mean, at least in my hands, I don't have the ability to judge which one will need the peeling or not. In my country, in Poland, people that comes to me, their holes are usually more than 400. So I rarely see those very, very small holes. And some time ago, I did a small study with my patients, and the average time with a macular hole in the region that I was doing the surgery was 13 months, average. That means they actually go with the macular holes around the area for more than a year before they go to they find the vitreoretinal surgeon.
Your thoughts on transplants?
Retinal transplant.
Autologous retinal transplants.
I don't have any experience with that. I tried amniotic membrane. I tried the plasma membrane created with a centrifuge. Pretty much in those cases, we are talking about very, very difficult cases. And I think that study should be done to collect a number of cases, because usually people report just a single case. And you cannot have a conclusion based on the single case, because you could be biased by either way, actually.
Dr.
So it's
Samir,
difficult.
any words of wisdom from your end?
Yeah, I think this is a very good discussion, and I totally agree. I think ILM peeling is the cornerstone of the macular hole treatment, and we most of us have plenty of cases with closed macular holes without the inverted flap before this year. But nowadays, in macular holes less than 400 micron, I do ordinary ILM peeling. Above 400 micron, I do inverted flap. And
How about the extra large?
extra large means 800 to 1,000, for example. I do inverted flap, of course, in these cases. Yes.
Okay. Dr. Ayhasi?
For more than 1,000?
For X large macular holes, I do always inverted flaps.
Dr. Ayhasi?
Yeah, before I comment on the extra large, I'll just have maybe a comment and question to Dr. Aganeska about the RPE-related macular hole. So we're talking about more of degenerative rather than tractional, isn't it? It's degeneration? Yes. Yeah. So in those cases, we may attempt to treat it the same way of treatment of lamellar macular hole, the degenerative type, where we use the macral membrane and embed it inside, like which has been shown in many papers that is very effective. And maybe we can fold on top of that one the ILM, hoping that it will close. For the I think in general, if you are treating a retinal detachment patient, you have your own hunch and thinking that this may close in a certain percentage. Macular hole, we do it, we don't know what is happening. Some of the small macular hole tend to be bigger after the surgery. Some of the big, large macular hole, they close with the classical way of treatment, which is only vitrectomy and inverting the ILM.
So again, for the large macro hole, I always attempt to do 360 island flap. For the small one, I just do the temporal flap.
Okay. And now you talked about the submacular hemorrhage. When do you decide to intervene surgically versus just doing an injection with the TPA?
Generally speaking, I attempt to treat all the cases with the submacular hemorrhage because you want to give the patient.
No, but I understand. But what I'm saying is, when do you take them to the OR
Yeah.
versus just a gas injection and TPA?
If the radius of the submacular hemorrhage is large, and I can see a big blip of
Define large.
of hemorrhage, yeah.
How large is large?
Yeah, I measure it using the OCT. If the thickness is more than 5 to 600 in thickness of the submacular hemorrhage from the RP all the way to the neurosensory retina, I will take the patient to surgery and I do subretinal TPA. However, the cases where the submacular hemorrhage is within the range of 400 micron, I found it in my hand. At least it's very effective to go with minimum procedure that you can do office-based, injecting of the TBA along with anti-VEGF if you are dealing with patient with AMD etiology, and then maybe the next day you bring the patient back, you inject him with small to medium size bubble of SF6 gas in 2 weeks. Most of the patients, they do very well, and this has been shown in the paper in general. But if maybe if you remember that I have shown some of the slides about massive macular hemorrhage, where the injection of TB in the vitreous cavity and placement of gas bubble is not really enough. So we want to give the patient the maximum benefit from your treatment. That's maybe the rationale.
And how old would you proceed? So, I mean, if someone comes and tells you, obviously, if it's 1 day, you probably say, okay, let's do it. But if it's 2 weeks, 3 weeks,
yeah. So
what is your time limit?
So the damage can happen as early as 24 hours. This is what experimental studies has shown. However, I have done cases where the blood turned from red to yellow, which is dehemoglobinized blood, and the patient actually was insisting to go for surgery. I was against the intervention because I know this is already clotted blood. I didn't show it in my slides, but the blood is almost like a concrete, so it's very hard to be removed. And once I did the vitrectomy, induction of PVD, I discovered that those patients, most of them, they do have already a kind of macular hole. So now you are dealing with different pathology. And it's really more damaging to go and create like retinotomy, removing this kind of clotted blood under the retina. It's easier to remove it through the macular hole and deal with the secondary pathology with the macular hole. Those patients, they did have closed macular hole at the end, but the visual acuity did not improve. So again, if I do remember one patient, I treated one eye. It's the same pathology, dehemoglobinized blood in both eyes. One eye was treated with only intravitreal TBA along with gas bubble because it was traumatic subretinal hemorrhage. The other eye was treated with vitrectomy and removing of the blood clot under the macula. Both at the end had a similar visual acuity at the end.
So I think at the end, it really depends on the underlying condition. So, if it is from AMD, even if you remove the blood, you still have to keep on injecting. Otherwise, you get into the same problem.
Yeah.
Anything you want to add?
As you said, of course, the cause of the submacular hemorrhage is the key role in this equation. I think I had made some cases with traumatic submacular hemorrhage just with hydropneumatic displacement of this hemorrhage by injecting saline and gas and air, under the macula. So this saline will dilute the blood, and the air bubble will make a space, yes, just to sweep it away, this hemorrhage from the macular area without the use of TPA. So I think the cause of submacular hemorrhage is the key role in the equation, how to proceed, how to inject, and what is the material are we going to use.
Yeah, but a key thing here, though, is knowing where the blood is. If the blood is sub-RPE, then forget it. You don't do any of these. It has to be subretinal, really, for this to work. Okay.
I did some study, and I had I actually did around 60 cases of subretinal hemorrhage in the macular area in AMD patients. And my observation is that usually those hemorrhages are located, they have mixed locations. Some part is under RPE, some part is under the retina. Sometimes it's very difficult to assess where the blood is actually, because with the high elevation of the retina, it's really difficult and it's really tricky. My statistics in 60 patients was that the location of the blood does not matter. And the size of the area covered with the blood does not matter for the final outcome. There are two parameters that actually matters: the state of the macula before the hemorrhage, and if the macula is just damaged. Even if you remove the blast, of course, the visual acuity will be better, but just slightly, okay? But if the macula is relatively in good shape, the visual acuity will be better. And the cutting point of the timing of the surgery in my patients was 30 days, which was very surprising for me, because it would be around 2 weeks. But even if there is 2 or 3 weeks, it's still worth doing. We need to remember one thing, that TPA is to actually dissolve the clot, and the clot is fibrin. So what you were saying about the fibrin under the retina, if you give the TPA under the retina with the clot underneath, it would help, because the clot would be dissolved. That's my understanding of how TPA works, actually. It doesn't work on erythrocyte. It doesn't, you know what I'm saying? It's just to resolve the clot, the fibrin. So actually, even if you give it after 2 weeks, in the 3rd week, it still might help.
Okay, very good. And Dr. Samir, regarding your macular buckles, are you concerned about choroidal ischemia?
I'm not concerned, because it's already present in this. Most of these cases, the choroid is ischemic at this area, and it's very thin sclera.
Yeah,
and
but if you push, you're gonna probably these, as you say, they're very.
Yes, I know. Yes,
they're very eyes with very limited choroidal perfusion.
Yes,
Aren't you afraid
right.
that you're gonna, because
you
know,
damage
Carlos
more.
Mateo from Spain has a lot of experience,
Yes.
and he says like long term, the problem is a lot of these eyes end up with atrophy in the macular area. What has been your experience?
Yes, we have. I have a lot of cases by endoblumb, more than 40 to 50 cases, and this was my PhD thesis without the modification. There is no much atrophy as we expected, and I think the vision improved after the buckling procedure in these cases. Most of these cases has atrophy at these areas, and this is one of the pathology of the myopic traction maculopathy, which is the RPE atrophy in these areas. So there is no more or much damage are expected from these buckles. After the modification by the light, I think the success rate is more. I don't have much experience about the abdomen. We have about 11 cases in our series, and this case I did it since about 1 year. I'm still following up the case. There is no much problems in the horizon. I think it's going well, but I have a concern that it's a very tough buckle. So I think we should do more follow-up to the patient, and we can't let the patient without follow-up because it's very rigid, just for the atrophy you are talking about.
Yes, please.
So what are the complications that could happen in the learning curve, or that you would have faced with the modification that you're using that is very rigid? So optic nerve traction and optic nerve injury that could happen.
I think by knowing the anatomy, it's very difficult to do optic nerve injury or something like that. It's not. It doesn't happen at all. One of the complications in these buckles is the migration of the buckle.
About
migration.
About diplopia.
No, we didn't have diplopia in these cases because we don't act on the muscles like the buckles. Like the 360 buckles. We don't go for the muscles, or we don't get sutures at the muscle level. I think it's migration. It's one of the complications we had seen. So we should take a good suturing technique and more than one suture technique, as I showed. There is no optic nerve or something like that injury. It doesn't happen. And the non-exact placement of the buckle at the macular hole, this is one of the causes of failure of this procedure.
Any of you have any experience with macular buckles? No, I have no experience myself, so, okay. You're the expert then. Yes?
So we used a buckle called the AGL buckle, in which we used a buckle called the AGL buckle. The AGL buckle, it's a customized buckle. You give the AJL. As a company, yeah. So when you give the axial length, it prepares the buckle for you so that it hits the exact fovea. And you have to suture it 13 mm from the limbus. It has a port by which you can put in a fiber optic, as you have done. It's a ready-made port, so when you do it, you can adjust it, and you just need to put one suture in the anterior part, and technically it fits exactly at the fovea if you've given a customized axial length measurement for the patient. So, but still, if there's a staphyloma, you can have a lateral slip on the staphyloma edge, so that's the most important part. Even if, like the case you saw, even if you suture it, if the suturing, or if the you can have a slip of the posterior most edge if it is resting on a staphyloma on a side. So that's the biggest challenge over there.
So do you ever consider doing vitrectomy in these cases rather than a buckle? And if so, in what cases?
You mean instead of doing buckle, we can do vitrectomy plus the buckle. I have cases.
And when do you when do you decide to do that?
Mostly in these cases, addressing the posterior staphyloma problem will solve the problem, okay? And this is the main target in these cases, and the main target of the posterior buckling techniques. But sometimes we have cases had done vitrectomy and failed, especially in the myopic macular hole retinal detachment. So you can do post procedures, but vitrectomy is not advanced, or will give you something that the buckle will not give it to you. So the cornerstone, in my opinion, and in our work in these cases, is reconforming of the posterior pole will give the best success rate.
Okay. And a question for Dr. Nair. So you talked about biomarkers in DME. Do you actually use them on your day-to-day to decide what treatment you're going to give these patients?
So some of the biomarkers we do use, I'm not a big fan of the drill biomarker.
It's very hard to really assess.
It's very hard to read the parallelism, the drill, but the two biomarkers which I personally feel are really useful are the hyperreflective foci. The hyperreflective foci, checking them out, could give you an indication of an intervention of whether to use a steroid instead of anti-VEGF. There are indications that these could be inflammatory markers also, an inflammatory marker. So the higher number of HRF in fluid or a high amount of turbid fluid in a cyst could indicate two things. That is, you don't go in for a very aggressive flattening of the CME. You could get subfoveal hard exudate migration. You should check the lipid profile before that. And the other thing is that a steroid might work in reduce.
So you would use a steroid as first-line treatment in
not
these
as
cases?
first-line treatment. If
So
I
you
s-
still do an anti-VEGF
I
as
still do
first-line?
an anti-VEGF, but I have we're publishing a study called OS Prime where we prime the eye with steroid before. When there is a lot of turbiditis, we prime the eye with Ozurdex steroid before we give anti-VEGF. That's just a study we did. But essentially, looking at the hyperreflective foci and the amount of large OPL disruptions or cysts are the two main things that really help in day-to-day practice when you do it. So some of these are very resistant to anti-VEGF and they respond better to steroids. That's it.
So recently, the people from Roche have talked about using faricimab, and they talked about these hyperreflective foci, and they say that the faricimab can get rid of these better than than aflibercept, for instance. So would you consider using that instead of the steroid because of the safety profile, or you still use the steroid?
For me, my first preference is still an anti-VEGF. So if there is overwhelming evidence that faricimab is going to work, I'll use that first. But I'm not. I'll have to use it and see rather than just take the clinical trials on like that.
Okay.
Thank you very much for a nice presentation. I have a question for you. I saw some of your slides presenting a patient with very elevated RPE layer. Yeah. So in those cases, if you don't have any subretinal fluid, so we assume that this is sign of like silent disease or there is no more activity. So is there any like measures or parameters you depend on to at least stage what is the next stage of treatment? Will you stop the treatment? You are on the other side afraid of the RPE rep with such huge retinal pigment epithelial detachment. So is there any approach?
So basically, I would like to answer that in two ways. One is what is the scenario in which the large PED is found? If you are seeing a treatment-naive de novo patient with a large PED, no activity, there is no form of treatment. But the recurrence of a PED in any previously treated AMD is a sign of recurrence of the disease. The SRF may not be there yet. The IRF may not be there. But the recurrence of a PED is taken as recurrence of the disease and it has to be treated. Now, the key feature in these points are the extra large PEDs. You have a high risk of RIP with and a high risk of RIP without treatment also. So the best for the patient would be probably an informed consent, telling them the chance of RIP, and if it comes in a setting where the PED has recurred after, or the size or the height of the PED has increased after you have treated the patient with anti-VEGF, that is an indication for treatment. Yeah, if it's stable and it doesn't increase, so if you after you do your exit strategy, if it's a treat and extend or if it's a PRN, you do your exit strategy. You said you've decided your finished treatment. There's a PED, you observe it, it hasn't changed size. That is an acceptable form of cessation of treatment or exit. It's acceptable. Like SRF is acceptable now, a PED which is stable is acceptable now. Thank you.
Any other questions? No? If not, I'd like to thank my panelists for wonderful talks and for keeping in the time. And I will wish you a happy stay in New Delhi and the rest of the meeting. Thank you very much.
Thank you.